Hi, I'm Steve Selling, founder of Fit Test, and in this second part of my 5-part series on the recently published European Society of Cardiology guidelines on sports cardiology, and particularly on exercise in patients with cardiovascular disease and cardiometabolic disease. In part two, I'm just going to talk about some of the less common conditions: myocardial bridging, anomalous origins of coronaries, very common heart failure, of course, heart transplant, and very common valve diseases. I'm going to focus just on aortic valve and mitral valve on the left side of the heart, but there's also information of the right-sided cardiac valves, tricuspid and pulmonary, in the guidelines that you can easily access. And as I did in part one, you can get these guidelines in all of the forms, from full text down to pocket guidelines and even a slide set. All of this is freely available. So now we come to the first condition I'm going to talk about here, and that's myocardial bridging. A myocardial bridge is where part of an epicardial artery tunnels through the actual muscle, the actual myocardium, as is shown here, with a thin myocardial bridge going into thick bridge, and then a very thick bridge here. And then you can even get very thick with myocardial hypertrophy here. And again, this is shown in in longitudinal form as being normal here, and then partially tunneled here with just a small amount of tunneling, and then larger and larger amounts of tunneling. And of course, as the larger and larger amounts of tunneling occur, you can imagine that at some parts in the cardiac cycle, these arteries here are squashed, physically squashed. So even in the absence of coronary artery disease, the physical squashing of these arteries can produce symptoms of angina or symptoms of ischemia, such as angina or chest pain. And so when we go to the more severe forms of bridging, these can become potentially symptomatic. Now, myocardial stele refers to a squashing during systole of this epicardial artery, and it then steals blood from smaller vessels that may be joined in some other way through collateralization. That's what stele refers to. And then you can get coronary artery vasospasm in relation to this contraction of the muscle around it. If it's then complicated with upstream coronary artery disease, that makes it worse. And much worse then is if you get a dissected artery. So now coming to the recommendations in the guidelines regarding clients or patients with myocardial bridging. I'm just going to focus on the red underline. Competitive sports are not recommended in individuals with myocardial bridging and persistent ischemia or complex cardiac arrhythmias during maximal exercise testing. So again, this is pointing to the fact that, first of all, we want to know if someone has got a myocardial bridge. Hopefully they've produced enough symptoms along the way. They've become symptomatic if it's severe enough. They've then gone and got further investigations, and you as an exercise professional can then benefit from that. And you can then really frame or shape your whole exercise service from pre-exercise pre-participation exercise testing, and then pre-participation exercise planning, if you know what the person's got and what's been done about it. Okay, so that's the situation. We want the medical practitioners to be involved here. Of course, what I've underlined here means that competitive sports are not recommended. So the level of recommendation is 3. In other words, not recommended, but the level of evidence around the recommendation is only at the C level. In other words, it's an expert opinion. Now, coronary artery compression together with a venturi or suction-like effect are the potential underlying mechanisms for the ischemia. We now come to anomalous origins of coronary arteries, or AOCA. And just to explain in pictorial format, first of all, so I'm going to go through A, B, C, and D sets of diagrams. So in A, we have the normal setup of the coronary arteries with the right coronary and the which is anterior to the pulmonary artery, left main coronary artery anterior to the pulmonary artery. And there's no compression here at all. There's no lack of space for these major coronary arteries. And so there's no compression here with the origin. But if we go to B, clearly you can see that now the left main coronary artery has traversed through the small gap between the aortic valve and the pulmonary valve. And so when in exercise, when both of these valve annuli increase in size, and certainly the muscle in here increases in contractility, it's very susceptible to squashing or physical compression of the artery. And if this is the left main, this can cause all sorts of havoc in the form of even the potential for lethal arrhythmias, or certainly ischemic symptoms, signs and symptoms of myocardial ischemia. And this is simply because of the origin of the left main coronary, then traversing through between the aorta, the aortic valve and the pulmonary valve. And then that divides into the left circumflex and left anterior descending. In C, the left main coronary is traversing through the septum. And again, through this muscle here is then susceptible to compression. So it's then passing through here and then before it divides into LAD on the other side of the pulmonary valve. And then in D, although it's wrapping around the aortic valve before it, and then around the pulmonary valve, there's no compression. There's no shortage of room for these major epicardial arteries, and so it's not a problem. So with anomalous origins, it really depends on the course that these arteries traverse in relation to the major landmarks of the aortic valve and the pulmonary valve. Participation in most competitive sports with moderate and high CVD demand among individuals with anomalous origins of coronary arteries with an acutely angled takeoff or an anomalous course between the large vessels, that is the large valves, is not recommended. So not recommended means recommendation 3, but again, low level of evidence and really based on expert opinion. Now we come to recommendations for exercise prescription in heart failure, and we can break that up into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, and even heart failure with mid-range ejection fraction. So the first thing you need to do with your clients who have heart failure is you need to talk to them about what they want in terms of an individualized exercise prescription for people with heart failure. And you know my views on pre-participation screening and assessments. You really must do that. Now, exercise-based cardiac rehabilitation is recommended in all stable individuals with heart failure to improve their exercise capacity, quality of life, and to reduce the frequency of hospital readmissions. And then you can see them beyond cardiac rehab, unless, of course, you're working in cardiac rehab. So you would then see them when they come back out into the community, out of their rehab program. Now, down the bottom here, the recommendation, high intensity interval training may be considered in low risk patients who want to return to high intensity aerobic and mixed endurance sports. Now, notice here, the experts, first of all, the level of recommendation leans towards not recommending. So it's a 2B level of recommendation, but the evidence again is not strong. It's really based on expert opinion rather than randomized clinical trials. Now that said, I'm not those of you who know me will know that I'm not a fan of high intensity interval training for patients with severe heart failure, that is, patients with at least class 2, but especially class 3, class 4 heart failure. I simply do not apply high intensity interval training to these patients. because the risks far outweigh the reward. Now, in terms of sports in heart failure, before considering a sport activity, a preliminary optimisation of heart failure risk factor control and therapy is needed. And that might include devices such as pacemakers or defibrillators. High intensity power and endurance sports are not recommended in patients with heart failure with reduced ejection fraction, irrespective of symptoms. That's very important. Should have underlined that in red. High intensity power and endurance sports are not recommended in patients with heart failure with reduced ejection fraction. Again, the level of recommendation is 3, of course, but the evidence level is only at C. Now, with preserved ejection fraction, moderate endurance and dynamic exercise, together with lifestyle intervention and optimal treatment of cardiovascular risk factors are recommended. Competitive sports may be considered in selected stable patients without abnormalities on maximal exercise testing. So again, that would point to a level of, or a very high intensity exercise test before you start working with a patient. Now, a lot of us are interested in aquatic exercise for individuals with heart failure, and I'm sure a lot of us have all been down to the local pool and seen the older clients in these aquatic exercise classes where they're standing, exercising in, say, chest deep water. Now, the science suggests that would recommend it against that form of exercise for patients with heart failure due to concerns of central blood engorgement. However, the clinical practice data suggests that it is not harmful. So we're sort of in a bit of a bind there. But I think overall, I don't think we need to be too worried clinically about this situation. We'd much prefer the clients are doing this form of exercise if they can, when they've got arthritic hips and so on. They're not doing exercise at all. So I've had to come to the view that this form of exercise is good, is recommended, and even though the science would argue against it. Now, for heart transplant, regular exercise through cardiac rehabilitation, combining moderate intensity aerobic and resistance exercise, is recommended to reduce cardiovascular risk imposed by the post-transplantation medical treatments and interventions, and does improve clinical outcomes. The level of recommendation is strong, that is level 1, and the level of evidence is based on at least one randomised clinical trial for this recommendation. And I'm sure that this level of recommendation, the level of evidence will improve with time. Now, for down the bottom here in red type, no high intensity exercise or sports, especially body contact or other activities that carry risks of traumatic injury should be permitted in these patients. Factors influencing decreased exercise capacity in the case of peak VO2 and reduced cardiac output in individuals after heart transplant. I'll just load this red sentence at the bottom. A major limitation of endurance exercise is the reduced chronotropic response to exercise because of the denervation of the donor heart. It goes in denervated. In other words, there's no nerve conduction to the sympathetics to drive up heart rate. So there's this reduced heart rate response. However, there is a good literature on the fact that there is a gradual reinnervation of the transplanted heart, but it doesn't reach complete reinnervation, but it does reinnervate to some extent, so that if you come back in 2, 3, 4, 5 years, there will be a better chronotropic or heart rate response to exercise as the patient goes further and further away from their heart transplant event. So that's really the first stop point here, cardiac allograft denervation. There's diastolic dysfunction of the transplanted left ventricle, reduced peak exercise and end diastolic and stroke volume by 20%, increased pulmonary capillary wedge pressure, myocardial ischemia due to cardiac autograft vasculopathy. That's well described in the literature, vasculopathies. Hopefully that improves with time. Impaired peripheral vascular endothelial function, increased systemic vascular resistance by up to 50%, decreased skeletal muscle oxidation, oxidative fibers, mitochondrial performance, enzyme activity and capillary density, reduced AV difference by 25%, and elevated sympathetic activation peripherally, not in the heart muscle. So there's a lot of things going against, but certainly my experience with cardiac transplant is they do really well post-transplant with an exercise program. Now, coming to recommendations in individuals with aortic stenosis, and again, I've produced 3 YouTube videos on this topic, and I recommend you search for me, Steve Selig, on YouTube to access those videos on aortic stenosis. I'm not going to cover it in great depth here, but what they're saying with severe aortic stenosis, that is with a left ventricle to aorta drop in pressure across the diseased valve of up to 40 millimeters of mercury, that's severe. Participation in competitive or recreational sports exercise of moderate and high intensity is not recommended. So really, if you've got people with severe disease, they need to be down to low intensity, low volumes of exercise only. Now, that is a recommendation at level 3, but also the actual amount of scientific evidence around this is quite weak, and it's really based on expert opinion. Now, the dot point above that is participation in all recreational sports and exercise involving low intensity, if desired, may be considered in individuals with left ventricular ejection fraction and above 50% and normal blood pressure response during exercise. So that's some guidelines for severe. With the moderate, you can just read those guidelines, and mild, you can pretty much do anything you would do with someone without aortic valve disease. Remember, however, that aortic stenosis is usually a progressive disease. It doesn't stand still, so you need regular, as in at least annual, sign and symptom vigilance, and you need medical review of their aortic valve at quite regular intervals. They need to be in the care of a good general practitioner and probably a cardiologist. Now, coming to aortic regurgitation now, I'm not going to really cover mild and moderate disease. You can read those there. But for severe disease, now this is where the aortic valve leaks during diastole back into the left ventricle. Now, that can then cause a dilated left ventricle. So participation in all recreational sports involving low and moderate intensity, if desired, may be considered with a mild or moderately dilated left ventricle. Now, when the left ventricle is dilated severely, in other words, extensively, then the left ventricular ejection fraction will start dropping because the heart is now stretched and engorged with blood during diastole, and it is not capable of pumping more than 50% of that out during systole. So left ventricular ejection fraction can drop below 50%. Now, if that's the case, then participation in any moderate or high intensity recreational exercise is not recommended when the level of aortic regurgitation becomes so severe that the ejection fraction drops below 50% due to left ventricular engorgement during diastole. And this, of course, has associations with arrhythmias because it can then feed back into the atria as well, particularly with the mitral valve disease. Now, finally, I come to mitral valve disease. I'm only going to cover mitral regurgitation. As I said, the full guidelines will give you information on mitral stenosis as well as the right-sided valves. So just to go to the severe disease again, with mitral regurg, which means the mitral valve leaks backwards into the left atrium during systole. Here, participation in all recreational sports involving low and moderate intensity, if desired, may be considered in tightly controlled conditions. Now, obviously, this would require extensive analysis and testing, probably by a cardiologist, or certainly by a cardiologist. So the tight conditions are left ventricular end diastolic diameter is less than 60 millimeters of mercury, and or less than 35 millimeters per square meter in men and 40 millimeters per square meter in women. So that's the size of the left ventricular dilatation. Left ventricular ejection fraction more than 60%. Resting pulmonary artery pressures less than 50, systolic that is, and a normal exercise test. So these people need a good workup with mitral regurg before you can give them participation in recreational sports involving even low and moderate intensity. So we're really talking about pretty restrictive exercise and sports involvement in people with severe mitral regurgitant disease. Now, down the bottom there in red, mitral valve regurg or prolapse can be associated with myocardial scarring in the region of the mitral valve and the region of the leak, and also produce conduction defects and arrhythmias. Here are again the references, with the top one being the 10 Commandments and the actual guidelines being the second reference. So thank you for watching this second video in the 5-part series on the European guidelines. And as always, you can contact me at info@myfittest.com.au, and please go to my website which is myfittest.com.au. All the best, and thanks for watching this video. Bye for now.